Hi, my name is Carlos and I am a Disease Intervention Specialist from Multnomah County, a DIS. My pronouns are he, him, they, them, and my role at Multnomah County, like many of other DIS, is to connect with anybody that has newly been diagnosed with HIV to make sure that they know of their test results, that they understand what being HIV positive means, and the resources that they are out there for the community. Make sure that they have a primary care provider, and we help them notify their sex partners to make sure that anybody that might have been exposed, they can get tested and connected to resources like PEP and PrEP. Another thing that we do is if they don't have a primary care provider, we help them get connected with the clinic that we have here at the health department, clinic upstairs, to get them connected with Rapid Start, meaning that they can start medications within like sometimes the same day or within like 5 days of seeing somebody. And what I do, making sure that they are okay, they process their emotions, then I connect them to the front desk, and that will be with Elizabeth, and help them move forward on the next step.
My name is Elizabeth. My pronouns are she, her, hers, and I am part of the front desk team. So once the patient connects with us, it's my job to collect their information, such as name, mailing address, social security number, and phone number. I also ask them their demographics, such as race, ethnicity, country of origin, veteran status, preferred language, and if they need additional assistance during their appointments. I also ask them their housing status and income information. Once this all has been entered into Epic, I send their medical record number to one of our intake specialists, either Laurel or Elwood, and do a warm handoff.
Hi, my name is Laurel Kurtz. I use they, them pronouns. I'm the eligibility specialist at the Health Services Center. Once the front desk staff completes their portion of the Rapid Start new patient screening, they'll do a warm handoff to me, and from there I will ask the person a number of questions to learn what kind of insurance they have, or what kind of insurance they'll qualify for. If a person has insurance but it's not Medicaid, there is a possibility that they'll experience some obstacles in acquiring their medication, and so if that's the case, we're able to do a bridge with them so that we know that once they see their provider, they can leave with their medication in hand. So I'll determine whether or not that's necessary, and if it is, I'll go ahead and complete that application with the person. And if the person comes to us and they don't have insurance and it's outside of an open enrollment period, then we also will work with Care Assist to figure out a temporary solution so that they are able to be seen for medical visits and procedures and ongoing medication help until there is an open enrollment period where they're able to get a more permanent solution. And from there, I do a warm handoff to the intake coordinator, Elwood.
Hi, I'm Elwood. Pronouns are they, them, or theirs, and I'm the intake coordinator. I get a new Rapid Start patient a couple of ways. Either somebody is brought upstairs from DIS, or they call the clinic or walk into the clinic to refer themselves, and it kind of comes through the front desk, and they'll chat me or call me. Or sometimes I'll get a call from an outside provider like Planned Parenthood or an emergency room somewhere, and we'll set up an appointment from there. And then when I meet with someone, two things can happen. One, I might just be screening them to sit there like, hey, I just got the news downstairs. I don't want to do a whole intake right now. We might just screen and set up the appointment, and I might spend time, just talking about what the process will look like. Or they'll say, hey, I'm ready, and we'll kind of jump in from the intake right in that moment. Either way, I send out a message to the nurse, the team, provider, the pharmacist, and the lab, and the insurance eligibility specialist, and let everyone know, and so they can start working on their parts while I talk to this person. And when we're done, we've done the paperwork, I will, depending on kind of timing of the provider appointment, because it kind of revolves around when that availability is, I'll take them to the lab. I'll have chatted the lab first to say, hey, they're coming, and then I walk over with them, and then I kind of follow someone through their whole process. And from the lab, maybe the MA will room them to their provider visit, but then afterwards I might check in with them. I might walk down to the pharmacy with them and help them fill a prescription, and then introduce them to their case manager down the hall, and just try to orient them to the
Hi, my name is Amy, and I'm a clinical pharmacist, and I'd like to explain my role in our Rapid ART program. My role begins when I receive an urgent EPIC message letting me know that we have a new rapid patient starting soon. Usually, hopefully, that message contains their insurance information. If we don't have it that day, we tend to get it before their provider appointment, and usually gives me enough time to start looking into their insurance to make sure that the medication that we want to prescribe is covered, is affordable, and is accessible, meaning that they can either get it in our clinic pharmacy or a pharmacy in the area, or even mail order. We want to figure these things out ahead of time so that we are removing as many barriers as possible to access, so that our patients can leave the day they see our provider with their medication in hand. And anyone who's worked with insurance knows that even though it sounds straightforward and easy, isn't always. Insurance has often put up a lot of barriers to access to medication. So my job is to try to figure out what those barriers are ahead of time and remove them, so that we know that our patient leaves the day they see our provider with medication in hand. Once that is done and complete, and we know that, I hand this off to our team nurse, Alicia.
Hi, my name is Alicia, and I'm a registered nurse at Multnomah County's HIV Health Services Center. When a nurse is notified that a rapid start is coming, it's through a priority in-basket message that's sent in our EPIC message system. It comes directly from the intake coordinator, and it tells us when the patient was diagnosed, any urgent information, and when they're scheduled. These are top priority because these patients are generally scheduled in 1 to 2 business days, and sometimes same day. And if it's same day, we're likely going to get an in-person phone call, or our intake coordinator will walk over and tell us, hey, this person's coming, and get on it. In the normal circumstances for an intake, the nurse will go and meet with the patient before the provider, and we'll get to know them and get to know their health history and really summarize that in the chart and make a plan with them. But in the rapid start setting, they're going to meet with the provider instead of the nurse for a rapid start visit. So in this case, we do chart abstraction. We'll go in and we'll check Care Everywhere, which is a system where different hospitals and healthcare providers can talk to each other. We'll look for any recent notes. We'll look for notes from their past provider, if there is any. We will look at any diagnoses that they might have, any urgent issues. Have they been to the urgent care or the emergency department recently? And we will summarize everything we can find in the chart. And also we will enter labs. It's about 14 or 15 labs that we'll enter, and about 6 different diagnosis codes. So we make sure that all the lab orders are in, because when they come, that's one of the priorities, is to get them started on labs and on meds. And then from there, we're going to send that over to the provider so that they can have a chance to review prior to their visit. During the provider visit, we may be called in for extra support, such as if there was an issue that needs to be taken care of, like a STD or something else. We might be called in for a little bit of assistance, sometimes wound care, things like that. And then at that visit, they're going to fill out their health history form. And so we'll do a later addition to that chart abstraction with anything that we might have missed, family history that they filled out, smoking history, things like that, that we'll add into the chart. And then finally, about a month after, we're often asked to do phone calls just to check in and say, hey, how are things going with your meds? Any issues with adherence? Any questions or side effects that you think you might be having? And just kind of check in from there to help develop that relationship and keep them in care.
Hi, my name is Sam and I use they, them pronouns. In the intake process, I'm the phlebotomist, and when I get the client, the patient, from our intake coordinator, Elwood, I make sure that they understand that we will be drawing multiple tubes, as this can be a scary experience, especially someone that is newly diagnosed. I also make sure that they're comfortable if they need to lay down or not. And then I also ask if they have any concerns or questions. We really just want to make sure they're as comfortable as possible because this can be a very scary experience. Once that's done, I make sure to do the rest of my job with the drawing the tubes and all that and the processing as quickly as possible so they can move on to the next portion of their intake process, which will be a warm handoff to the provider that they will be seeing so they can get their medication.
Hi, my name is Mary Tager. I'm a physician assistant, one of the providers in the HIV clinic. So when I have a patient on my schedule for a rapid ART start, I'm usually notified by seeing that on the schedule. Generally, one of the staff will also let me know during the day. Oftentimes, the intake coordinator or the nurse will let me know during huddle, give me a little bit of background on the patient. So when I meet with the patient, we talk about their testing history, talk about whether they've had any previous negative tests, initially sort of start with how they're doing emotionally with the new news of the diagnosis. Generally, when I see the patient, they've been diagnosed with HIV within the previous 24 to 72 hours. So oftentimes there's a lot of shock and surprise to deal with, and that's mostly what we spend the visit on. We also go over their medical history, any other comorbidities that they're dealing with, any other medications that they may take. The nurse has done a chart abstraction for me, so I'm able to see any available previous medical records, labs, any other pertinent medical information. So we do a brief medical history with the patient, review of systems, and talking about the initial parts of living with a chronic illness and taking medication every day, and get a sense of whether they feel like they're able to do that. We also will review whether they've been diagnosed with any other STDs at the time that need to be dealt with and follow-up needed. When I'm done with the patient, I take them to the lab if they haven't already been to the lab for all of their initial HIV labs. They then will go to the pharmacy to pick up their HIV medication. Generally, we're starting people on Biktarvy. They get generally a call from the nurse 1 to 2 weeks after that initial visit to check in and see how they're doing with the medications, go over any side effects or any other issues, and then I see them back again in clinic after about 1 month to review how they're doing, go through a full medical history, physical exam, and review all of their lab results.